Good. Yes, sir. Good evening, Anton, sir. Today we'll be discussing about a 71-year-old male who had a CAD status for CABG since 20 years on October 2003, systemic hypertension for 20 years since 2003, dyslipidemia for 20 years, BPH from 2013, CKD from for 3.5 years, on hemodialysis for 3 months, and he did a CAG 4 weeks back, and now presenting with complaints of pain and discoloration of toes since past 5 days. So her pulses are felt distally, and now she is having multiple erythematous uh, papules over her toes, and possibly since she had history of CAG which was done 4 weeks back, and this typical history, if it can be due to a cholesterol emboli, possibly, sir, uh, embolizing into the toes. And in this patient I will look for the fundoscopic picture for a Hollenhorst plaque also, and the patient may also have other symptoms. Okay, she's having gangrenous lesion on the left small toe, sir, possibly due to myocarditis, which can happen after any kind of invasive procedure, sir. Possible diagnosis: digital ischemia. Um, Possibility which I would consider would be cholesterol embolization to the small vessels, causing uh, blue toe syndrome. Uh, yes, sir. The possible occlusion would probably be distal to the dorsalis pedis, sir, because the dorsalis pedis, the posterior tibial, every pulses were palpable. So this occlusions would be in the small arterioles and arteries, sir. Small vessel. Micro. If the limb is, if the vessel is gangrenous, then uh, it has a poor prognosis. Otherwise, the other lesions, it will resolve. Oh, okay, sir. Okay. Oh, oh. These patients, we wouldn't heparinize. Uh, I'm not quite sure about the same, sir. Oh, oh. Oh, oh. Yes, sir. Okay, sir. Yes, sir. Very good case. So the yes, sir. Cholesterol embolism, vasculitic, the vasculitis, and the site. Why we chose cholesterol embolism is possibly due to the site when the extremities are involved following a procedure. We would suspect this case, and the pulses were felt, sir. So it would mimic a small vessel vasculitis. Okay. So coming to the next history, she's a 45-year-old female with no comorbidities, having a BMI of 19, with complaints of episodes of sweating, palpitation, and dizziness, and a tendency to fall while getting up from the bed. And she was admitted to the medicine department for evaluation of hyponatremia, where the sodium was 124 and the GRBS was 70. So, considering this history, so she is a 45-year-old female, uh, in her not obese, in is her correct with a correct BMI, having episodic sweating and palpitation and dizziness, and with postural hypotension. So I would surely consider a pheochromocytoma in this patient, and she is admitted to the medicine department for evaluation of hyponatremia, which is 124. So hyponatremia can be due to many reasons. It can be and a GRBS of 70. GRBS of 70, it is normal, or otherwise it can mean that the other counter regulatory hormone is not so much. Count. Uh, so, sir, is there any other clue for the after this history, sir? In pheochromocytoma, hyponatremia, if there is any kind of IC bleed, then it can in turn produce SIADH, and then there can be blood glucose. Would be it is actually a catecholamine. It's actually a counter regulatory hormone, which should increase the glucose level, I suppose. Oh, she's having a hyperpigmentation of her hands and of her. So it can, the possibilities now can be a Addison produce Addison's disease, then megaloblastic anemia, but megaloblastic picture is not there. So it can, other possibilities, Addison's disease, sir, with associated hyperpigmentation. Addison, B12 deficiency, then other in face, if it is there, it can be due to amiodarone. Then in hands specifically, in joints and cartilages, it can be due to onchronosis. Then I'm not. Yes, sir. Yes, sir. In gastric malignancy, especially, there will be acanthosis nigricans, and then in it can be a paraneoplastic syndrome, sir. Yes, sir. For after treatment of malignancy, then if we give radiation or any specific chemotherapy, it can induce a pigmentation by itself. Otherwise, it can cause Addison and as well as the hyperpigmentation, sir? Yes, sir. Addison's disease, the ACTH has a similar the it's actually released as a pro-melanocortin and then it's divided into melanocyte MSH also. So the MSH stimulates the hyperpigmentation, sir. Addison's disease, there would be knuckle hyperpigmentation in the extremities, in the inside the mouth, also in the mucosa especially. Oh, oh. Yes, yes, darker, sir. Thank you, sir. Addison's, we would supplement the patient with steroids, and if the patient presents with a Addison crisis, then we would prefer IV steroids by mainly hydrocortisone, 100 mg TID, and if the patient after controlling the acute scenario, then we would shift the patient into TAP prednisolone, usually 40 mg, 1 mg per kg initially, and then taper. Usually we start with 40 mg here, sir, and then taper weekly. And also, according to many resources, it had been said that we would preferably keep a Addison wristband where we can say that we are having this Addison's disease, and especially in case the patient has surgery, then we would double the dose of the steroids, and or in any case of stress, we would double the we would increase the dose of steroids also, sir. A patient, if she's asking, depends. Pigmentation, uh, I'm not quite sure, sir. Possibly reversible, sir. Oh, yes. Oh, okay, sir. Okay, sir. So here our diagnosis was yes, sir. Yes. Yes, sir. So coming to the third case is a 47-year-old female with complaints of severe acid rash and one episode of hematemesis for 6 months and a breathing difficulty with episodic syncopal episode for 3 months and spots over the face for 2 months. So, dissecting the history, she's having severe acid brush and one episode of hematemesis for 6 months. So, it means that possibly she is having severe reflux disease, producing a possibly she would also have a Barrett's. And then she is having breathing difficulty with episodic syncopal episode. Breathing difficulty could mean that she is having considering the previous history and also the spots over her face, which could be telangiectasia also, and which could mean that she is having something like a scleroderma. Scleroderma can be a possibility in this patient, and the breathing difficulty can be due to either an anemia or a interstitial lung disease with episodic syncopal episodes, sir. So my differential, yes, sir. My differentials at first would be always scleroderma and and also possibly a limited scleroderma maybe, and she's having episodic syncopal episode. It can be due to maybe a severe due to severe pulmonary hypertension or arrhythmias, and uh, then uh, other differentials would be other things which she would have is a Barrett's esophagus also, sir. Oh. She's having spots on her face and possibly with a kind of a beaking type of nose, and then uh, she's having microstome. Her lips are bit like a bird beak type, and then she's having rashes on her chest also, and she's having this bit puffy rather but tight hands, skin over her hands, sir. uh, it's yeah, yes, sir, in the thumb at the lateral aspect, and telangiectasia so over her thumb is also there, sir. So other differentials which I should consider would be a hereditary hemorrhagic telangiectasia in case the patient has any family history, sir. Uh, yeah, sir. The primary differential would be a scleroderma system, limited. Yes, sir. So it's Crest syndrome. Possibly, main thing is she was having esophageal dysmotility, symptoms of pulmonary hypertension, and gas body, sir. Hello. So her diagram has becoming uh, uh, into pulmonary hypertension. No, sir. Limited scleroderma, pulmonary hypertension, gastric antral variceal ectasia, vascular ectasia, and multiple syncopal episodes, possibly due to the same pulmonary hypertension, sir. Severe. Yes. First case was a cholesterol embolism, atherembolic disease due to CAG. Second one was Addisons disease